Good evening, Namaste and welcome to 8th Respiratory Conclave Conference 2022. Thank you to each and every one of you for being here with us today at Respiratory Conclave Conference. I would like to thank all our guest speakers and chairperson. We are very pleased to be able to welcome those of you that have been with us for a long time since we started our journey with Respiratory Conclave Conference. And now as well as those who are new to Respiratory Conclave Conference. Just to inform you that this is our 8th edition of Respiratory Conclave Conference. Since last 2 years we have been doing this conference through online only, just because of COVID protocol. But this time it will be on hybrid mode. Like every year, this year also we have come up with burning topics. And regarding the same, I would like to call Sakshi Pathak. She is a daughter of Dr. S.K. Pathak. She is studying in IMS BHU to tell in brief about our topics, speakers, chairperson and more about Respiratory Conclave Conference. So I would like to call upon Dr. Sakshi Pathak. Sakshi.
Thank you, Abhishek ji. Good evening, everyone. Myself, Sakshi Pathak. I'm a final year medical student at IMS BHU. First of all, I would like to thank Dr. S.K. Pathak sir and the team of Respiratory Conclave Conference for giving me this opportunity to welcome you all. It's my pleasure to welcome all the eminent speakers and guests from all over the country to the 8th Respiratory Conclave Conference, which is being held on 24th of July 2022 in Hotel Radisson in the holy city of Varanasi, the city that illuminates truth and reveals reality, the city that resides on the bank of holy river Ganga, where the eternal lights intersect the earth. This conference is organized by Breath Easy Chest Foundation for Humanity in association with IMA Varanasi and is sponsored by Breath Easy Chest Super Specialty Hospital Assi and Breath Easy Multi Specialty Hospital Ramnagar. In the past 2 years of COVID pandemic that created a havoc on the medical fraternity, we stood together and organized this conclave to educate and enlighten everyone about the deadly virus and the pandemic norms. Some of the world's most esteemed medical professionals like Dr. Randeep Guleria sir, Dr. Rajendra Prasad sir, Dr. Suryakant Tripathi sir became a part of the online conferences we conducted in the past 2 years. And it's our pleasure to inform you all that it's the first time we are conducting this conference in a hybrid mode, that is both online and offline. We have over 10,000 online viewers with us right now. This conference is also recognized by UPMCI and all the delegates will get 3 credit hours for this conference. You could also download online certificate for the conference after the sessions are over. For any queries or assistance regarding the online certificate, you can contact our help desk organizer. It gives me immense joy to share with you all about the newly established Breath Easy Multi-Specialty Hospital Ramnagar. We were so disheartened to see the lack of oxygen and beds to the poor during the pandemic that we decided to help them by establishing our second branch in the suburbs of Ramnagar to make medical facility more accessible to the poor. Over the 10 years of establishment of Breath Easy Chest Super Specialty Hospital, we have treated lakhs of patients and conducted more than thousands of health seminars and health camps in both rural and urban areas. And by God's grace and yours blessing, we hope to treat and help even more people by improving and developing our facilities. I would also like to thank our medical director and founder of Breath Easy Hospital and this conference for giving us all the opportunity to come together and have discussion on burning topics in the field of respiratory medicine. Dr. S.K. Pathak sir, you truly are an inspiration for young doctors like us. Your story of how a young clueless child became a well-renowned chest medicine specialist by just doing hard work and your unmatched dedication to help and serve the society is something that encourages us to put our hard work in this field. And I would also like to thank the mentor of our conference, Dr. Rajendra Prasad sir, Head of Department, TB Chest, Eras Medical College, and former ex-director Vallabhbhai Patel Chest Institute, and former HOD TB Chest Department KGMU Lucknow, who is the organizing chairman of Respiratory Conclave Conference. We are truly grateful to you, sir, for being our guide in the past 8 years and motivating and educating us to improve ourselves every year, and hope for you to be our guiding lights in the years to come. Now, I would like to share with you all 2 video messages from Dr. Suryakant Tripathi sir, HOD TB Chest Medicine, KGMU Lucknow, Dr. Tariq Mahmood sir, HOD TB Chest Medicine, Motilal Nehru Medical College, Prayagraj. Due to certain unforeseen circumstances, they couldn't join us here today. So here are their video messages.
Success of this 8th Respiratory Conclave Conference organized by Dr. S.K. Pathak. Dr. S.K. Pathak did his MD from Department of Pulmonary Medicine, King George Medical University, Lucknow. He has been our student, and during his 3-year MD residency, he did a lot of community work also, along with the MD curriculum. He is practicing very nicely in Varanasi and has gained name and fame in last few years. And he is regularly organizing this conference, and this is the 8th time that this mega event is happening in the city of Varanasi. Unfortunately, this time, due to some family problem, due to some unusual, all of a sudden death of the family member, I'm not able to attend this conference, but my best wishes for the grand success of the conference is there with the Dr. Pathak and with this conference. And I think with the presence of esteemed speakers, faculty members, and the grand audience from the Varanasi, this conference will be a grand success.
Here is a video message from Dr. Tariq Mahmood sir.
Good evening. I congratulate Dr. Pathak for organizing the respiratory conclave at a physical conference after 2 successive years of virtual conference. I am thankful Dr. Pathak for invitation to me. I am not able to attend due to some program in the family, so I will miss it, and I am sorry for that. Definitely I will miss the scientific deliberations during the conference, and I will also miss our respected teachers, and most importantly the Professor Rajendra Prasad sir, Professor J.K. Samaria sir, Professor J.K. Mishra sir, and our teacher Padam Shri Professor K.K. Tripathi sir, our friend Dr. King Raja Dhar from Kolkata, and our colleague from Varanasi and around Varanasi. So it will be a great conference, and I wish Dr. Pathak my best wishes for the grand success of conference. Thank you very much.
Thank you, Dr. Suryakant sir and Dr. Tariq sir. We are extremely grateful for your wishes. Now, the schedule for today's conference will be as follows. The topic for the first session will be terminal lung disease, and the speaker for this session will be Dr. Rahul Chandola sir, Associate Director, Max Hospital, New Delhi. The topic for second session will be lung attack, and the speaker for this session will be Dr. Rajadhar, Consultant, CMRI Hospital, Kolkata. In the third session, there will be a panel discussion on heart and lung attack, that is dual attack, and the speaker for this session will be Dr. A.K. Pandey sir, Senior Cardiologist, Varanasi, Dr. R.K. Singh sir, Emergency Medicine Specialist, SGPGI, Lucknow, Dr. S.K. Pathak sir, Senior Pulmonologist, Varanasi. In the fourth session, there will be a discussion on respiratory pearls in clinical practice, and the speaker for this session will be Dr. Rajendra Prasad sir, Professor and Head of Department, TB Chest Medicine, Eras Medical College. There will be a case presentation in between the second and the third session by Dr. Swapnil Pathak, Resident Medical Officer. The duration of session 1, 2 and 4 will be of half an hour and the duration of session 3 will be of 1 hour. At last, there will be a token of thanks by Dr. S.K. Pathak sir, followed by dinner. So now let us begin with the first session. I would like to request Dr. Swapnil to escort our chairman for this session, Dr. Amit Jodi sir, pulmonologist Varanasi, who is also our session coordinator, Dr. Sanjay, Department of Cardiovascular Surgery, IMS BHU, Dr. A.D. Shukla sir, pulmonologist Varanasi. Thank you. Now I would like to hand over the session to Dr. Ashish Jaiswal sir, cardiologist Varanasi. Now I would like to hand over the session to Dr. Amit Jodi sir.
Good evening everybody. At the outset I would like to congratulate Dr. S.K. Pathak for his consistent efforts for continuing a scientific program for the last 8 consecutive years. It's a very big thing and we are proud of him. So the first topic as we see is regarding management of terminal lung disease, and with this what comes to our mind is the lung transplantation. So most important thing about this is that the role of chest physicians in referring the patients to the transplant surgeon, and even more is the timing of the referral. The timing of the referral is so crucial that if you are late in referring the patient's prognosis is not good. But at the same time, if your decision is very hasty, your diagnosis may be wrong and you may land yourself in a dicey situation, because the most common cases that we refer for transplant are IPF, COPD. But what is happening with IPF is that many patients are diagnosed IPF, but they are having some other problem. There are many patients who are having hypersensitivity pneumonitis and they land with some other person and then they realize that their diagnosis is wrong. And giving the diagnosis of IPF is like giving a death certificate, because we all know that the prognosis is hardly 3 to 5 years. So we all need to be very, very versed and crystal clear about diagnosing such cases and referring the patients in time, because delay and too hasty decisions are both wrong. So with these words, I would like to call Dr. Chandola. He has so many credentials that it will be difficult to read out everything, but he has published research papers in reputed international journals of cardiac surgery and thoracic transplantation, and his areas of interest are adult complex cardiac surgeries, aortic surgeries including root reconstruction, lung transplant. So may call upon Dr. Chandola to please deliver his lecture. Thank you.
Good evening, everybody. I'm Dr. Chandola. I am a cardiothoracic surgeon at Max Hospital, Sake, and it's been a pleasure to be called upon here. I'm really thankful to Dr. Pathak and feel that I'm fortunate to be attending this conclave. I'll the topic allocated to me is, the management of end-stage lung disease, which is quite a broad topic. But because I'm a transplant surgeon, so most of the things revolve around IPF and COPD. IPF mainly, ILD, interstitial lung diseases mainly. So I'll try to revolve around my specialty rather than the other end-stage lung diseases. So. So with that, we know that most of the indications for lung transplant, majority of patients are patients with interstitial lung disease. IPF being a very common interstitial lung disease amongst them. Roughly around 35-40% of patients that we receive in the West, they were patients with ILD. In India, it's a different situation. Almost 90-95% of the patients that we operate have ILD. For some reason in India, we do not get referral for patients with COPD, as opposed to in the West, where close to 35-40% of the patients who get lung transplant are having a diagnosis of COPD. So with that, I'll start. I'm told that I have to cover some medical management also. I do not feel specialized enough to cover that, but I'll just cover the basics of that. So IPF, as we know, that is a chronic, progressive and irreversible interstitial lung disease. It's the most frequent of the devastating ILDs that we see. As a mean survival of 3 to 5 years following diagnosis. The progression is really fast, and the treatment includes medications and non-pharmacological plans. So traditionally, as for the IPF, cocktail treatment comprising of prednisone, azathioprine, and N-acetylcysteine used to be used, I think, a couple of decades ago. But that has not been found to be of much consequence, compared that to the placebo. Not much survival or disease progression, any difference in the disease progression or in the survival was found in either groups. So, but recently with the introduction of pirfenidone and nitidanium, the things have changed, and there have been trials that clearly show advantage of these two medicines. So with the pirfenidone, it has got anti-fibrotic and anti-inflammatory properties, and there have been many trials that proved that the decline in the FVC and the functional capacity, which was measured in terms of the 6-minute walk test, and also sometimes with the maximal oxygen consumption, the cardiopulmonary exercise testing, it has been found that pirfenidone, it reduces the decline of FVC and its functional capacity with almost a 43% reduction of IPF progression or death as compared to the placebo. Similarly, with the nitidanium, which is basically a angiokinase inhibitor that targets the fibroblast receptors, the platelet-derived and vascular endothelial graft and fibroblast receptors. So it is involved. These three receptors are mainly involved in the pathogenesis of the IPF. And this nitidanium has been found to cause inhibition of all these three receptors. And as a result, it has also been found to reduce the decline in the FVC, and also has been found to cause reduced exacerbations of the IPF, and has been found to increase the quality of life in studies so far. Whether or not there is a survival benefit, that's a questionable thing. Some studies have shown there is no survival benefit. Some smaller studies have shown the survival benefit as well. Another important treatment modality for the patients who suffer from IPF is the treatment of gastroesophageal reflux, which is quite common, almost as many as 88%, 90% of these patients. Chronic microaspiration has been thought to be triggering the development of the disease and the progression of this disease, IPF, and hence anti-reflux treatment has been the mainstay of treatment. One of the important arm of treatment. to a level where it is inadvocated even in the asymptomatic IPF patients. It has been seen that the anti-reflux treatment decreases the progression of the IPF in some of the studies. Newer studies are refuting this, but there are some bigger studies that have shown significant improvement. One of the very important things that we have quite a good exposure and experience with is pulmonary rehabilitation. So it's an important part of our lung transplant program. And we know that for sure. Rest of the medications we are not very sure how much they help. But one thing that we're sure that this pulmonary rehabilitation is such an important tool. And especially the patients that we receive are quite moribund. They have very decreased functional capacity, exercise capacity. They come to us with those very weak peripheral muscles, weak respiratory muscles. They're so deconditioned that even while you're talking, they will desaturate. And to get these patients to the level where they can tolerate a big operation like transplant is a challenge. But we start these patients as soon as we see these patients in the OPD. We put them in the pulmonary rehabilitation program. And this program, is a very comprehensive program where not only on the endurance building and exercise, there is a focus on the nutrition as well as the psychosocial, elements are taken care of. This is very important. Generally the regime that we follow is 3 to 4 weeks of at least 45 to 1 hour of session. We ask the patient to come at least 3 to 4 days in a week and continue that for 3 to 4 weeks. And generally by the end of 1 week, we do see significant improvement to a level where the patient, when comes to us, he is a 6-minute walk distance, say of around 50 meters, 60 meters, 70 meters. And by the end of 1 week, we can see the improvement. The 6-minute walk distance gradually improves. Most of our patients, if they don't have, they are very particular about this rehab program. They come regularly. At the end of 6 weeks, we have seen there is a tremendous improvement in 6-minute walk distance. So for us, the cutoff is 250 meters, before we take the patient for the transplant. And many of these patients are able to achieve that, even though when they presented to us, their 6-minute walk distance was around 40 meters, 50 meters. So that is the power of pulmonary rehabilitation that we see. And it's not really expensive. For one session probably they charge us 700 rupees. And imagine, they've been taking these medications for so long. They've been in and out of ICU with so many comorbidities. Already spent so much of money on the treatment. But this pulmonary rehab really changes the things for them. So in addition to improving the endurance, it also helps build up the small and large muscles, the intercostal muscles, the diaphragmatic muscles. At the same time, it improves the quality of life. And in many studies, actually, it has been shown to improve the psychological response, as opposed to the placebo. So it's a very important tool and strong tool. Patients who have IPF, they all should be subjected to the very specialized pulmonary rehabilitation program. Now, oxygen support, long-term oxygen should be provided to IPF patients. Even though there is no survival benefit, when using oxygen, which was compared to patients who received colchicine or corticosteroid in one large retrospective study. But it may allow these patients to remain physically and socially active with better quality of life. Moreover, with higher oxygen support, these patients can attend the pulmonary rehabilitation and hence their cardiac endurance, the muscle strength, and the appetite, nutrition, all of that improves tremendously. So oxygen support is a very important tool there. Now with that, I'll come to my topic, which is lung transplant. It is proven to be a very effective means for patients with end-stage lung disease, prime indications being the IPF, COPD, cystic fibrosis, and even in the patients with other septic lung diseases like bronchitis. As Jory sir said, that timely referral to a transplant center is so vital because before these patients get deconditioned, before they get their PA pressures go really high, before the RV dysfunction ensues, or the other organs take hit, it is important to get them referred to a transplant center. So indications, as I was mentioning, most of these patients, this is a Western data, by the way. So as you can see, most of the patients who get the lung transplant, main indication is ILD. Around 35-40% of the patients have a etiology as ILD. The same proportion of patients having COPD or emphysema. Small number of patients presenting with cystic fibrosis, and a very small proportion of patients, who have lung transplant for primary pulmonary hypertension or small population with isolated or retransplantation. So main indications are IPF and COPD. So this is a small history. It was started first human lung transplant. It was started in 1963 by Dr. Hardy. Patients did not survive for almost 20 years. There were 40 failed attempts until 1983. Dr. Cooper at University of Toronto did the first successful single lung transplantation. But imagine the persistence with which these researchers and the surgeons and the whole team of physicians persisted with the intent of improving the outcomes for patients with end-stage respiratory diseases. If those initial couple of attempts would have dissuaded these surgeons or these physicians, probably lung transplant would not have come this long. So in 1983 it was started. Actually, patients survived, and gradually the refinements in the surgical and the post-operative ICU care, the outcomes have now become really good. So indications, as I mentioned, mostly for the COPD patients, or the patients with interstitial lung disease, and a small number of patients with cystic fibrosis and bronchitis. So lung transplant for IPF, just wanted to cover this slide. Timing of referral is very important, as was mentioned. Generally, the patient should be referred, to a transplant center when the diagnosis of ILD is made, and there is any associated dyspnea or functional limitations secondary to IPF. Any oxygen requirement, even if only during exertion, these patients should be referred to the transplant center. They may not be listed for transplant at this time, but actually they should be seen by the transplant physicians by now. Patients with abnormal lung function with deranged FVC, and DLCO, they should be referred. When should they be listed for the transplant? Actually, they should be told that, okay, now you get listed with the National Organ Transplant Registry, and now your time starts. You just have to wait for the organ to come by. You can be transplanted anytime. So this should be done when these patients with ILD have a decline in FVC more than 10% during the last 6 months. So any decline of more than 10% in 6 months' time is an indication that this patient is going to go down soon, and it has to be listed for the transplant. Or any patient who desaturates to less than 88%, or the 6-minute walk distance goes down to less than 250 meters. This is the time when we know that these patients do not have a long-term survival. They should be referred to the lung transplant center. Any diagnosis of the secondary pulmonary hypertension, patient with a PA systolic pressure of more than 40-45 millimeters of mercury, we know that now this patient will have poor survival, and he should be referred for the lung transplant. Any hospitalization in a patient with ILD for acute or chronic respiratory failure or pneumothorax should be referred for lung transplant. Similarly, a patient with COPD, when should a patient with COPD should be referred for transplant? The timing of referral is progressive disease despite maximal treatment. When the patient is not a candidate for surgical lung volume reduction surgery. The board index is around 5 to 6. If the PCO2 is more than 50 millimeters of mercury, or PO2 less than 60 millimeters of mercury, or if the FEV1 is less than 25% predicted, they should be referred for transplant. When should they be listed actually for the transplant? And they should be told that, okay, well, you now need transplant. Any patient with COPD with a board index of 7 to 10, or at least having one of these following, the acute exacerbation with hypercapnia, or 3 or more severe exacerbations during the preceding years, or patients with PAH, or when the FEV1 and DLCO is less than 20%. These are the patients who should be referred for the lung transplant because they do not have a long-term good prognosis. So, this is quite a common observation. For those patients whose COPD patients whose PCO2 was 50 millimeters of mercury or more on ICU admission, 1-year mortality in one of the studies was as high as 43%, which is quite significant, and that tells us, when these patients, the urgency and the requirement, these patients to be referred for the transplant. Now, what happens, when the patient is referred to us for transplant? We do the pre-operative assessment of this patient. We see whether or not the patient fits the bill, whether or not we can be transplanted. And obviously, we do all the surgical, pre-surgical investigations. Important ones amongst them is the panel reactive antibodies. These are the antibodies in the recipient that determine, how much are the chances that this patient is going to have rejection in the post-op. So if the panel reactive antibodies are high in the recipient, this patient will be a high risk for rejection in the post-transplant. Any patient with more than 25-30% or more of panel reactive antibodies in the serum will probably not be a good candidate for lung transplant. We do the imaging studies, the CT scan for the extent of involvement of both the lungs, and which lung is involved more, that gives us an idea. The CT scan gives us an idea. Echocardiogram is a really important tool to know the RV dysfunction and also the PA pressures. The patients with RV dysfunction or high PA pressures are poor risk candidates. We do the right and left heart catheterization to see to quantitate the right-sided pressures, and we do a lung perfusion scan to see which lung is involved most. So as a result, patient with COPD who we plan to do a single lung transplant, we would like to perform the transplant on the worst affected lung. Or if we are doing a double lung transplant, we would like to take out the lung that is affected most as the first lung, and do the second other lung as the second lung, the sequential transplant. So it is very important to know which lung is affected most, and this is done with the help of this lung perfusion scan. And then rest of the tests are done. Bronchoscopy is important to get the bowel cultures and know exactly if the patient is doing any organism and deal with these organisms in the pre-operative period. So there is a very strong donor organ program in our country, mainly headed by National Organ Transplant Tissue Transplant Organization, which is called NOTO. So as the patient comes to us, we do the pre-transplant investigation, and also if the pre-transplant investigation shows that the patient is a good candidate for transplant, we would list him with the NOTO, the National Organ Transplant Registry, and then his time starts. Generally, the time taken to get a healthy donor is anywhere between 1 month to 3-4 months. And an average of 2 months is the time when he can look at reasonable chances of getting a suitable donor. Now, the donor lung criteria, this is the ideal donor where the age is around 20 to 45 years with a PF ratio, PO2 by FiO2 ratio of more than 350. donor should not have a smoking history. The chest X-ray should be clear. It should not be on ventilator for more than 5 days. From microbiology, there's gram stain, and the cultures from the ET secretions should be gram stain negative, and the bronchoscopy should be clear. An expected ischemic time, the time when the donor lungs are taken out from the body to the time they are implanted into the recipient should not be more than 4 hours. But it's very difficult to get all these. This is the ideal donor lung. It's not really possible to get that ideal lung. You always have to compromise on something or another. So this is as soon as we get the alert from the donor hospital, say if I'm working in Max Hospital, Sarkhe. So if you get the alert from, say the last patient, we got alert from Ahmedabad. So our whole team goes there with this card, as you can see. It carries a lot of perfusion items and instruments. And there is a cooling jacket here where we get the lung in the ice box and bring it back in this card. So the whole team goes there and we assess the lungs, we assess the lungs with the bronchoscopy, with the arterial blood gases and gram staining and all those tests, and after that we are sure that we want to take these lungs. Then we open up the chest, and these are the lungs that you can see. These are all pink lungs, good looking lungs. I'll show you the bad lungs. So these are the lungs of a 21-year-old boy from CNC Balor. Got these lungs from Ahmedabad, from government hospital in Ahmedabad. And these lungs are looking quite pink and healthy to be harvested. So we got these lungs from there, and the flying time was around 2.5 hours to Delhi, and then total ischemic time was around 4.5 to 5 hours, which is well within the expected range. These are the lungs when they are brought back to the recipient hospital. This is the back table dissection where we are dissecting out the pulmonary artery, pulmonary vein and the bronchus for a subsequent implantation. So it could be a single lung transplant. You can see it could be done through a posterior lateral thoracotomy or sometimes through the atriolateral thoracotomy also. Or it could be a double lung transplant. I will just show you the example of a single lung transplant in this case. So the case is of a 29-year-old lady who was diagnosed with scleroderma and ILD as a result. FEV1 was like 30% predicted, FVC was 35%, she was on 5 liters of continuous oxygen. You can see the lungs, barely any lung tissue there. So all typical honeycombing both the sides. Badly destroyed lungs, and she was progressing quite fast. So this was the lady who got single lung transplant. Now, the double lung transplant generally is a sequential transplant now. We take out lung from one side, do the implantation, then we go to other side, take out another lung and implant another lung. As opposed to the non-sequential one which was done previously where they were implanted en bloc, like the anastomosis used to be in the trachea with both the lungs attached. But generally what happened was there were a lot of problems with the anastomosis and there were a lot of leakages and the patients died because of the leakage in the tracheal anastomosis. And hence now a sequential anastomosis is done with bronchus on one side and then another side bronchus. And that anastomosis is working quite good with very few days since in the post-op. So all the technological advances have really made the lung transplant success in today's time. You can see this here, the double lung transplant in progress. This is the new lung. Patient has been put on cardiopulmonary bypass. These are the venous cannula, this is the arterial cannula. The whole heart is taken on the bypass circuit, and then we do the transplant on one side, go to the other side, and do the transplant on another side. Double lung transplant here. And this is the incision. You can see the incision goes from one axilla to the other axilla. Quite a long incision there. The chest is wide open, like it has been divided in between. It's called a clamshell incision, and with this we do a double lung transplant usually. So this is the patient who got that single lung transplant. Now here, you can see these lungs, you compare that to the previous lungs. These are the lungs of a smoker, but this was the donor. And there, this was offered to us from CMC Vellore. But initially we were hesitant to take these lungs, but the PF ratio was good. And when we reached there, we also did the pulmonary vein sampling, and we were happy that the gas exchange was good. And our recipient was quite sick. She was on BiPAP, continuous BiPAP support. So we thought, that's our only chance. We took these organs and transplanted the patient, outpatient. And this is the patient, almost now. So this is 6 months post-transplant. Now he is almost like 4.5 years post-transplant now with the liver lung transplant. This patient we got had COPD. We did a minimal invasive, single lung transplant with this patient. A small incision. You can see the extent of incision. It's very small incision there, and just improved his quality of life. He was off oxygen after almost like 3.5 to 4 years on continuous oxygen. Very good quality of life after that. So all these patients who got the lung transplant. This patient, from Chennai, he had a board index of 7 and 2 hospitalizations in a year. He got lung transplant. This is 1 year after transplant. He is doing that, regular exercise. Even he, participated in one of the marathons in Chennai for the flood relief victims. The quality of life can be really good in these patients. Most of the patients have got good quality of life. Now, the advances that have happened in the lung transplant recently are, we are often encountered with a situation where the lungs that are offered are not good. So the acceptability rate of the lungs, the donor lungs, is only 15%, 15 to 20%. We compare that to the heart. The donor heart acceptability is around 35 to 40%. And you compare that to liver, almost 70 to 80% acceptability. The kidneys have almost like 95% acceptability. So in comparison to all the organs, lungs are so friable. So these donors, when they are in the ICU, they are on ventilator for 4 or 5 days. They're growing number of bugs. At the same time, many of these patients, when they got the head injury, they aspirate. As a result, they have aspiration pneumonitis. So they're not suitable organs. And then also, one important thing is, we always compete with the kidney team. Kidney team, they flood the patient. They want the kidneys to be flushed, for a subsequent good kidney transplant. On the contrary, we want these patients to be dry. Lungs need to be dry, otherwise they are flooded and the gases go down. So all these challenges are there, and that's why across the world, the donor acceptability rate for the lung is only 15 to 20%. So imagine 100 donors that will be offered, and of them you can only accept 50 to 20 donors. Compare that to kidney, where 100 are offered, and they are utilizing 95 of them. So lungs really are very, very friable transplant. One of the challenges with lung transplant. So recently, ex vivo lung perfusion is a technique that has evolved in the last 7, 8, 10 years, and now it is doing really good. So where the donor lungs are put on normothermic bypass circuit, where they are continue to ventilate and being perfused, from the time they are taken out of the donor body, and then they are taken in that form to the recipient hospital. As a result, the organ quality and lungs are also impaired in this process. So this is one important development that has taken place, and that has led to increased pool of the donor lungs. So now, previously, 3 to 4 hours was the flying time, which we were accepting. But now with this machine, you can take this machine with us, you can put the lungs on this machine, and then even if it takes 8 hours, 10 hours, 15 hours, doesn't matter. Their lungs are being perfused and ventilated, and that way we can increase the donor pool. And also the lungs are being repaired in the process. So even the bad lungs, which are flooded lungs, they get dry and their oxygenation improves in many cases. So this is quite a significant development in lung transplantation. This is a picture of that, where inside a dome there is, so you can see these lungs from the donor, they've been taken out of the donor body and they've been put inside this dome, where this is connected to the ventilator here. So ventilator here, and then there is a cannula in the pulmonary artery. There is a passive cannula in the pulmonary vein, and with that, the lungs are being perfused and also ventilated. And the solution which is used here is a steam solution, that causes lungs to get dry over a period of time, and they also have good osmotic properties. As a result, there is a constant healing of the lungs as well. So more and more lungs can be transplanted. With the use of this machine, the lung acceptability has gone up to 35% in some of the studies. This is lung in a box. This is a box that you can carry with you. So with this box, you can carry this box with you to the donor hospital and just put the lungs very far off places. Like we were in Edmonton, which is the west of Canada. We used to take this machine even to California, which is almost like 7-8 hours from there. The total ischemic time will be like 10 hours, 12 hours. But you put the lungs in this box, and just literally you can take whatever time you want, 10 hours, 12 hours, 14 hours, bring the lungs back in and do the transplant as an elective operation rather than an operation which can be done in the night. It's a hurried thing, most of the transplants are done in emergency, generally in the night hours. So the things have changed quite a lot with the lung transplant and how we manage end-stage lung disease. In last, this is the whole set. So this machine can be easily, it's a portable machine. You can take that with you to the donor hospital, get the lungs in the machine and bring it back, do an elective operation. This is one of the double lung transplants that we did recently. This patient was a patient with COPD, bullous lung disease, significant PAH, and as a result, he was in and out of the ICU, was in ECMO for almost 10 days. He got lucky and got the organ from Ahmedabad. We got the lungs in 2.5 hours from there. Total ischemic time for the first lung was around 4.5 hours. For the second lung was around 7 hours. And this patient, we continued him on ECMO for almost 7-8 days. Gradually, he was weaned off from the ECMO. Then discharged from the hospital on almost 16th day. Was doing quite well. So with that, I will just sum up with this slide. There is a hope here for patients with the end-stage lung disease, the patients with COPD and IPF with really no other solution except for surgical transplantation. Thank you so much.
Thank you so much, Rahul Chandola, sir. Now, I would like to call Dr. S.K. Pathak, sir, to present Momento.
Thank you, Dr. Rahul Chandola, sir. And our chairperson, some questions. This is some short time because Dr. Rahul Chandola flight is 10 o'clock. So he wants to go as early as possible. So within 5 minutes, we have to close the question session.
I want to congratulate you, Dr. Rahul, for your wonderful presentation. And I know that I'm the only surgeon around probably here who could understand most of the things what you said. However, I have certain questions which from practical point of view, I want to ask you, because having worked in the situation where you do heart, lung transplantation, in the Indian scenario, which do you think is easier to run a program of lung transplantation compared to the heart transplant?
Yeah, you're right. It's logistically very difficult to run a lung transplant program, especially the biggest challenge I think is to form a good team. And the second challenge is the donor organ availability. So with the heart, I do the hearts also, and I can tell you, heart transplant is way easier than the lung transplant. Lung transplant depends on lots and lots of things, and I would say the surgeon's role is a small part of what's happening with lung transplant. So majority of good work is done in the pre-op period and in the peri-operative, in the post-operative period. Surgeon will transplant, you do a good job there, everything is good, but if the donor selection is not good, or the patient develops some kind of infection in the post-operative period, these patients do not do well in that case. So to have a very comprehensive program at the same time, good donors available to you, that is also a challenge. What's happening is the organ donation is new to our country, and also the management of the donor lung before transplant is also, most of the centers do not know how to manage these lungs. They know very well how to manage the kidneys, they know how to manage the hearts now, but they are not very aware of how to manage the lungs. As an example, I will tell you, patients are on ventilator, and many of these patients will be on 100% FIO. For 2 days, 3 days, this patient, the lungs will be on 100% FIO, or the peak will be very, very high, or sometimes they will be flooded lungs. Like the kidney guys will say that, okay, well, give 100 ml, 150 ml per hour of normal saline or whatever fluid they want to give. They are on very high positive, they keep the patients positive. They just floods the lungs. Lungs are no longer usable. In the care that they get while the patient donor is on ventilator, there are no suctions that are done at that time. As a result, when you go in there, you do the first suction and you see all the muck coming out of there. So, that donor lung management is extremely important to have good outcomes. It's evolving in our country. Gradually time will come when we will get better and better lungs as we are getting to the West. There, the donor centers know exactly how to manage these patients. So now things are coming up. They will take a little longer, but I think lung transplant is a phenomenal operation that can do wonders to the quality of life now.
One last question. Do you think that, would you ever think about running a lung transplant program without having a successful ECMO program?
No, not at all. No, you can't run that. Because, most of our patients, will, many of our patients will need ECMO support. And now, I'll tell you, we are doing most of the transplants intraoperatively on ECMO. Because that has been seen to give better outcomes than the patients who do cardiopulmonary bypass. Because while on bypass, you have to give these patients a lot of tampering. And then, because the reservoir is there, there's a blood cell activation, systemic inflammatory response is more. If you compare that to the ECMO, and that's why most of the programs have switched over to the ECMO. So ECMO is an essential ingredient.
So if somebody is bridged on ECMO for a lung transplant, you won't bother putting the patient cardiopulmonary bypass. You will continue on the ECMO and carry on with the transplant.
Yeah.
Okay. And what about the survival? Because that's for everybody actually. Because unlike the solid organ transplant survival, I understand that lungs transplant survival is poor.
Well, I would say so let's put it this way. The 1 year survival with the lung transplant is now close to 85 to 90%. And this is not the Western data, this is the data from our country. These patients, so this is 1 year, and the 3-year survival is roughly around 65-60%. 10-year survival is almost reaching 45 to 50%. And 1-year conditional survival, these patients survive for 1 year. For the ILD patients, the 1-year conditional survival is almost 10 years, which is quite good. Yeah. So most of the care is needed in the initial first year. You survive that period, they do well for next year.
Thank you so much, sir, for nice presentation. Thank you so much.
So can I have one question?
Sure.
Single lung transplant is substitute for pneumonectomy. Can you
Like pneumonectomy for what indication?
any indication?
Not really. I mean, if the patient can, so generally, single lung transplant we do for patients where, they have come on oxygen now and the things are deteriorating fast. There's a decline in the FVC, as I said, more than 10% in the last 6 months, either because of COPD or IPF. These are the candidates for lung. Things are going out of the head, lung function is deteriorating, patients are requiring increased amount of oxygen. They should be transplanted.
Any unilateral disease?
Yes.
Even tuberculosis, whole tuberculosis.
Yeah.
Any disorder.
Yeah. So
Unilateral.
Yeah. So tuberculosis is one thing, where very limited experience with tuberculosis actually across the world. Few transplants have been done in China and Thailand. Not very elaborate data. And generally, there is always a risk of reactivation of tuberculosis after transplant because they are on high immunosuppression in the post-op period. So, not very sure about tubercular destroyed lungs. We have not done these
Actually,
patients.
Hyderabad was the first place for lung transplant. Is it right?
Yeah. No, actually Chennai.
Chennai.
So Chennai, the global hospital in Chennai.
Okay.
So we started the transplant. So when I came back from Canada, we started this program in global hospital Chennai. So 2013-14 we started, and we were doing close to 3 to 4 transplants in a month there. And then I came to Max Hospital 4 or 5 years ago. And another team went in there to Chennai. Hyderabad has started just now, like in the last 1.5 years.
Thank you, sir.
Thank you so much for nice questions and session. We have to rate here. We have to start Dr. Rahul Chandola for.
Actually, Dr. Rahul Chandola is having flight at the 10 a.m. When you should have started.
Hello, Deepa.
Sir. Ashwini. Sir.
We have to just honor our chairpersons for this conference. We have given a lot of time to discussion and some make a moment recordable. Pass out.